It is now a privilege for me to introduce our keynote speaker for this afternoon, Dr. Rich Barron, who is going to talk about clinical leadership through the perspective of the Centers for Medicare and Medicaid Innovation and CMS. Dr. Barron continues the pattern that we've had all day today of being a distinguished clinician in his own right. Currently, he's the group director for Seamless Care Models at the CMS Innovation Center. And as I said, he has a strong background in healthcare. He was a practicing physician at Greenhouse Internists in Philadelphia and was also Chief Medical Officer and Senior Vice President for Medical Affairs of Health Partners. And he's during that career in internal medicine and clinical leadership, he received the Level 3 recognition as a patient-centered medical home at Greenhouse from the National Committee for Quality Assurance. He's also collaborated with physicians in Medicaid health plans around the United States to improve care through the Best Clinical and Administrative Practices program, and he's a past chair of the American Board of Internal Medicine's Board of Directors, a current trustee of ABIM. They let you keep doing that? And a former member of the NCQA standards and the Board of Directors for the National Quality Forum as well. Rich is overseeing a number of initiatives that CMS has announced and a number that are in process now that go to some of the core issues that we've been discussing today about finding a pathway to reform payment to support clinical transformation in care, about finding ways to bring data from payers, in this case Medicare and Medicaid, into a better ability to support those efforts in the form of turning data that may not have been so timely in the past into more timely and actionable, a basis for actionable information, and a number of other initiatives as well. After Dr. Barron's remarks, we'll hopefully have a few minutes for questions and discussion. So Rich, please come on up. Thank you very much.
Thanks, Mark. There's really no audience that I'd rather be connecting with than you, who have taken time out of really busy schedules to show up and think about together the issue of what is the role of clinical leadership in healthcare innovation. And as Mark said, literally until March of this year, I was in a community-based practice. The reason I took the job that I have now is because I think a lot of it is about how we think about resources, and I hope by the end of a brief overview of some of the things we're doing at CMMI, we can have a conversation broadly about how thinking about resources is not limited to those of us on the payment side, but actually has a major role for folks who work on the delivery side. Really want to thank you for the work you do, and I think we really are poised for a major change for lots of factors. I think now really is different. I won't go through this. I hope many of you know this. There's a famous quote from Jamie Robinson. There are many mechanisms for paying physicians. Some are good and some are bad. The three worst are fee-for-service, capitation, and salary. Fee-for-service rewards the provision of inappropriate services, the fraudulent upcoding of visits and procedures, and the churning of ping-pong referrals among specialists. Capitation rewards the denial of appropriate services, the dumping of the chronically ill, and a narrow scope of practice that refers out every time-consuming patient. Salary undermines productivity, condones on-the-job leisure, and fosters a bureaucratic mentality in which every procedure is someone else's problem. Well, so there we have it with respect to how we're going to do physician payment. In the current system, clearly, we do acute care really well, but we have actually, I guess it's 50 million uninsured, and most critically for purposes of our collective conversation, uncoordinated, unsupportive, unsustainable. And we believe that innovation will transform healthcare from what's a producer-centered state to a patient-centered state, and we see ourselves as a payer as part of the solution. But I would invite you all to reflect on the ways in which your own institutions are organized as producer-centered organizations to get to the future system that we want: affordable, accessible, seamless, and coordinated, person and family-centered. CMS has a mission statement now. This was one of Don's high priorities. When I talk to physician audiences, I appreciate it when people don't burst into laughter when I present CMS as a trustworthy partner. It depends on how close you are to relying on checks from CMS to making your own payroll. Let's just say in physician societies, this is not a resonant mission. But it has been a really interesting organizing principle within CMS. And I think one of the things it's made people realize is that if we care about changing the delivery system from the payment side, we're going to have to do that in serious partnership and discussion with the delivery system side. And when we think about measures of success, we're thinking about the three-part aim, which is now embedded in the National Quality Strategy, so that the $1.2 trillion federal spend on healthcare has a purpose: better healthcare, better health, and reduced costs. And again, I would invite each of us to reflect on if that's really what we're about. How do we know if we're getting it? How do we align resource allocation and compensation and budgeting and all sorts of things with those goals? The Innovation Center, as I suspect most of you know, is created by the Affordable Care Act, and we are supposed to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing the quality of care. And we have $10 billion, which sounds like a lot of money, but it's about 0.1% of what the federal government spends annually in the Medicare and Medicaid program. But the coolest thing about the center is this opportunity to scale up, that if, in the language of the Act, to the satisfaction of the Medicare actuary and the secretary, one of our innovations works, does those things, the secretary can scale up that innovation throughout the Medicare and Medicaid program by administrative fiat rather than having to go to Congress for approval. So that's what caused a lot of us to run away and join the circus that is CMS. Our work is organized in three broad areas. Patient care models, which is basically bundled care, the community and population health models, which is still very much a work in progress, more sort of community health, public health. And then I do the seamless coordinated care, which is basically people over time and across institutions. So the major areas programmatically are variations on ACO models and models of high-value comprehensive primary care. In terms of how we actually do the work, we solicit ideas from the public, we select models, we test and evaluate the models, and we try to spread them. We consider ideas, define a concept, move them forward. This is to show that there's a bunch of things out there in our portfolio. The most recent, which I've already been asked about, was the Healthcare Innovation Challenge, which was announced earlier this week. I think the major thing I'd say about that for your purposes is that up until recently, we were advised by the Office of General Counsel at CMS that we did not have grant-making authority. We only had program authority. And so when people came to us with good ideas and said, will you partner with me on this, our response was, we'd love to, but we can't. Basically, the shape of this program is in light of a revised opinion from the Office of General Counsel. Maybe your lawyers never changed their minds, but the Office of General Counsel told us, actually, maybe you do have grant-making authority. So this is an opportunity for us to be supporting more individual kinds of proposals, the details of which are out there on the website, and I'd rather refer you to that than spend a lot of time talking about that because we have a lot of ground to cover, and I do want to leave some time for conversation. Broadly, as I said, a big part of my portfolio is advanced primary care practice models. And the major, I thought a lot about primary care before I joined the government, and a lot of leadership that I got to do at the board and in other places was to try to talk to colleagues about what do high-value models of primary care look like. And can't we move in that direction? Why is it that most primary care offices aren't doing email? Why is it that all over the country people make their patients come back for prescription refills or to discuss lab results? And in trying to develop some of those new models, the message I heard clearly from colleagues was, we'd love to practice that way. It's consistent with our professional values. It's why we went into healthcare in the first place. But we can't get paid for that. And we need changes in the payment system first. So now that I've switched to the payment side, I'm acutely aware that changing the payment system doesn't automatically give you the high-value primary care models that you're going to need to have, and that clearly we're going to have to do this together, that it is a shared problem, that to the extent that primary care, and this is going to be a theme in all the programs that I talk about, the delivery system generally has organized itself around revenue streams from a payment system that we all agree are dysfunctional, but that's how we've organized our practices. As we start reorganizing the payment system, we're going to need to see a reorganized delivery system to match it. And that's very true in primary care. Because it's a fragmented payment system, we were interested in multi-payer models. So the big initiative that we had out there was the multi-payer advanced primary care demo. That's where there were already states where multiple payers had gotten together and said, we are willing to pay more for high-value primary care, and where's CMS? And CMS came to be a guest at their table. But interestingly, if you look at those states, almost all of them had state-level, either legislative or executive action to suspend antitrust regulation for purposes of payers coming together to talk about new models of primary care and new payments for primary care. Without that, those conversations couldn't happen. And I learned in my second week on the job, when I proposed a program that would look like one of those state programs, I learned from my colleagues at the Department of Justice that such a program was collusion because the exemption available to the states to do this is not available to the federal government. So one of the challenges in terms of trying to coordinate payment for innovative models, that's something CMS is thinking a lot about. As a reference payer, as a standard-setting payer, can we innovate in payment in ways that other payers can parallel us, and will that be a big accelerant in delivery system transformation? And we do think primary care is critical, and I already talked about the way in which the barrier in transformation in practice is transformation in payment, and really looking at these additional models. To me, the most interesting thing about the Comprehensive Primary Care Initiative, the letters of intent for which closed yesterday, was the strategy of really trying to drive payer alignment. It's the first time CMS ever issued an RFA where the respondent was a payer, not a provider. And our idea in thinking about that was to say, everybody knows what an MRI of the right knee is. There's a CPT code for it. It's on the fee schedule. It's a clearly delineated specified service. Most contracts in the country are a % of what Medicare's paying. So we have this service. It's defined. We price it. People reference price it off us, and life goes on. What happens when you try to introduce a new service? Comprehensive primary care, patient-centered medical home, care bundles, call it whatever you will. Now you have two problems. You have the problem of you have to specify what that service package is in a way that we already did for the knee MRI, and then you have to price it. But if one payer does that, that may not be a powerful way to drive transformation in the delivery system. And certainly in primary care, a lot of the early efforts at patient-centered medical home projects that were single-payer efforts didn't do so well because it was a 3-foot rope for a 10-foot hole with one payer saying, sure, we'll support this, but the other payers didn't come along. So payer alignment is a critical aspect of what we're looking for in this program, which involves more generous support for primary care, up to $20 on average per beneficiary per month for Medicare. But I certainly want to be talking about accountable care organization initiatives and point out that the Shared Savings Program is a program congressionally mandated. I know you all could have told me that that's Section 3022 of the Affordable Care Act when Congress said to CMS, you will have a shared savings program. That's the thing for which the notice of proposed rulemaking came out in March that generated a healthy reaction from the community. And as John Blum said, we knew we were going to get it wrong. That's why we put it out there, so you'd tell us how to get it right. And the final rule came out, as you know, a month ago. The important thing about that program is it's a program. Anybody who meets the criteria is in it. It's there. It's a part of the Medicare system. We in the Innovation Center are doing variations on that theme, and sort of 3 things we did, and they can be thought of as to support that program because Medicare wants to learn a lot to make that program better. The Pioneer ACO model was targeted toward people in the delivery system who said, we're already there. We want global payment. We want to handle risk. We have the information systems. We have the clinical capacity, the integration. We think we can move forward with that. That's one end of the market. Another end of the market that everybody was worried about at the policy level is if the only people who come into the ACO world are large integrated delivery systems or hospitals, is that a situation where we've got the fox watching the chicken coop? Could we get some leverage involved if we get primary care docs being ACOs where they actually have a share of shared savings? Could we get that happening? And one of the problems was, would they have the resources to develop the infrastructure that they needed? So the Advanced Payment Initiative is targeted to that end of the market and explicitly to the small end of the market of if you don't have a lot of revenue to play with, you can talk to us about can you get some money up front to get into this program. And then we offer learning sessions to try to explain to people what this is, and we're actually doing the last one tomorrow and Friday, and they are going to be web streamed, so if people want to tune into that, they're free and available. But there are competing goals in trying to put together the ACO program, and it's important to think about those, that it really is a shared savings program. And one of the problems with some of the large integrated delivery systems is they say to us, so wait, you want me to give up $1 in revenue so that I can get 50 cents in savings? Explain to me how that's supposed to work. But those really are competing goals. If CMS doesn't save money in this program, we shouldn't be doing it. We're very worried about anti-competitive behaviors. If we drive aggregation in marketplaces, we've got data out there to suggest that maybe people raise prices when they consolidate market power. Shocking, but Bob Berenson has literature to suggest that is something that happens, so we worry about that. We do need to be able to say to the public when we create these environments that quality of care is preserved, so we need quality measures. We don't want to be totally burdensome about that. We got to do it in a hurry. We got to share data, just a bunch of different things going on there. And again, already talked some about this, but the critical thing about Pioneer is it moves in the third year under one of the tracks to truly global payment to the organization. And I'm going to ask this question for the first time of you now, but it's going to be the last question I ask you too. How will your organizations allocate resources and allocate salaries and budget support in an environment where fee-for-service has gone away and you're handling a global amount of money? And if the answer is you're going to turn to the bookkeeping systems you have in place and track RVUs, then we might as well never have bothered to put out a program like this. So we're really going to need to be thinking creatively together about what happens to the money after it hits the healthcare institutions. If we're trying to walk away from fee-for-service payment, we hope you are too. Talked some about the Advanced Payment Initiative, and again, it truly is advanced payment. And then the care bundles, again, talking about some opportunities here. I would make a couple of observations here. You look at a hip fracture, and whether it's your mother or your spouse or somebody, and they get the care they get, and then they start getting all these bills. And there's one from the emergency room, and there's one from the anesthesiologist, and there's one from the physiatrist, and there's one from the post-acute treatment place. And there's two questions that occur to me when I think about that. One is, is it a surprise that the person needed all of those services? And if so, if those are really all the services that they need, why do we buy them the way we buy them? Would you buy anything else that way? Would you buy anything else in pieces like that? And first, that's going to be the most expensive way to buy it. And second of all, patients begin to wonder, well, if they can't bill together, maybe they don't actually talk to each other about the way they provide these services, which many of us know turns out to be actually pretty perceptive on the part of some of the patients. So this is an opportunity to say, okay, we're going to put it together in a package. We're going to say what's in that package, and we're going to invite healthcare institutions to step up and say, that's the package we're going to provide. The first one out there now is acute care hospital stay only. It's for all DRGs. We're paying the hospitals, and the physicians aren't in the bundled payment physician services, but an opportunity for shared savings is available to hospitals and participating physicians. So hospitals can share savings in this program with physicians. But we want to move to models where they not only include physician and hospital services, but they include post-acute care, and ultimately to where they go to prospective payment. What does it look like to manage a DRG that includes post-acute care and all physician services? And again, we need to be thinking about that, and I hope we have ways to think about that that go beyond just the fee-for-service world. Partnership for Patients, I think many of you know about, again, a sort of broad patient safety initiative outside our usual frame, and the idea is that the government loses a lot of money based on unsafe care. Clearly, we're going at that with respect to some of the readmission stuff, but the idea is, can we help support infrastructure that would build patient safety? And many of you probably have signed up with the Partnership for Patients, but there it is. There's also the Community-Based Care Transitions Program. Since we know that a lot of the costs come with poorly managed transitions of care, not to mention a lot of the quality impact, can we create community-based organizations that represent this kind of capacity in communities? I think it's an open question whether the integrated delivery systems or hospitals will take this up on their own in a reliable, successful way. And so this is kind of a parallel strategy for that. Again, information about that. And then many of you know about the Innovation Advisors Program. This closed yesterday. I hope some of you even applied. But the broad concept is to try to have partners throughout the delivery system in the U.S. of people with whom the Innovation Center has a relationship, and people who are getting some training, additional training in a lot of the things that you all are thinking about today: leadership skills, change management skills, financial skills, quality improvement skills, and trying to get a little bit of that from us, but then be embedded in their home care institutions. This is a relatively modest commitment. The first wave of applications just closed, but there will be subsequent waves of this program. And it's a modest stipend and a modest commitment of time on behalf of the Innovation Fellows. And we're looking to deepen these skill sets. There's a Care Innovation Summit in D.C. that we're sponsoring in January. Again, information to hear about that. But broadly, what are we thinking about at the Innovation Center? We're thinking about how does the tool of payment drive and support innovation on the service delivery side. And one way to think about that, and I think in the most recent thing that we've released, the Innovation Challenge, we're functioning in a lot of ways more like the familiar model of a foundation. If you have a good idea, come to us. We'll support the good idea. If the good idea works, the world will know about it. We'll try to figure out a way to institutionalize it. It's an open question whether the best way to really do this is to be testing innovative service models, or whether actually payment models aren't ultimately more scalable. That if we have the right payment model, whether it's care bundles, whether it's ACOs, that create a different set of boundary conditions in which your organizations are operating, will you be able to operate in a way that moves us closer to three-part aim outcomes? And at the end of the day, that's what this is all about. That's what we're trying to do. And the question I would ask is, in that world that involves more global payment, in that world that has us as a payer and lots of other payers trying to run as fast as we can away from fee-for-service as a payment, what are you folks going to think about in terms of how you do everything from decide what the staffing is in the primary care unit, to how much you're going to invest in information technology, to what salaries you're going to pay to people who work in your institutions. So thanks for the opportunity, and happy to take some questions.
Thanks very much, Rich, and I think that'd be a good question to ask you as well. But let me instead turn to the people who are participating today. Questions or comments for Rich? Yeah, go ahead.
How are you? Bruce Hamrick from Geisler. Just a quick, because agreeing with the end point and understanding that the transition from where we are now to end state, is also a concern. Technology is very important.
So Bruce is asking about the transition from where we are now to the end state. Clearly a work in progress for all of us. I mean, so the Innovation Center is putting out these programs. I think the programs are accurately read as a signal of where we'd like to take a more accountable payment system. Now, between us and getting there are a number of things. There's, can we actually deliver the goods on the stuff that, or more accurately, can the delivery system deliver the goods with those new payment models? One set of issues. Another set of issues is, are they going to be feasibly scalable? But if I were out there, I would be looking at the Innovation Center models that I know I raced through, but I wanted you to be familiar with all of them, as a kind of roadmap for where payments likely to go. And your business is still your business, and it's still dominant fee-for-service, and it's still dominant composed of high-margin services. But I would not consider it prudent to predict that 5 years from now, that's still going to be a viable business model. And absolutely, leaders of delivery systems say to us, I feel like a guy with a foot on the boat and a foot on the dock, and I don't know what to do. And people can bet against whether we're actually going to change the delivery system. The thing I'm most struck by is the number of healthcare delivery system leaders that I meet who say we're pricing in a 10 or 20% cut in Medicare revenue over the next few years. Now, the building I work in, we're not saying publicly that there's going to be a 10 or 20% cut in Medicare fees in the next 5 years, but the market's starting to behave like that may happen. And I think people need to contemplate a world of less resources and how they're going to manage in it.
So Barbara and Tom, and if the questions go quickly, we'll get them both in.
Okay. One of my concerns as I read even the revised ACO model will be that the only mechanism that people can think of to get away from fee-for-service is full employment, which means that in markets where there is a dominant hospital or a dominant health plan, which is a significant percentage of the market, how then do you end up avoiding the situation where all of the physicians become employed, the costs then, according to MedPAC, go up, and there's no competition to allow new innovators in the area to compete, so the general prices just continue to rise and we get exactly what we don't want?
I think that's clearly one of the many nightmare scenarios to which we could be heading. I think the role of antitrust regulation with respect to physician aggregation and health system aggregation, clearly that's going to be an important set of considerations. The role of physician employment, ultimately what's going to happen is people are going to be doing a different kind of business than they're doing now. And meeting population health needs on a global budget, people are going to have to make some hard choices with respect to who they've employed and where they've allocated resources. And so if we're going to take cost out of the system, I would hope it would be a group of people looking at each other who actually have patient care accountability who are driving that conversation.
Yeah, Tom James with Humana. I'm aware of a number of physician groups around the country that want to engage in some of these different programs, but because they are relatively unsophisticated groups, they feel they can't make any application. Is there a help process? Because they all feel that it's going to be the hospitals and the large groups that will have the sophistication to be successful applicants.
So they should definitely take a look at the advanced payment ACO track because there is support there. They should probably look at the most recently released initiative that is pitched toward smaller groups of people.
I think we're about out of time, but I want to put you on the spot for one last, with respect to this question that you've put up for all of us here, the role of physician leadership in these new payment environments. What do you see as the biggest obstacle that physician leadership could help overcome in the efforts that you're trying to implement now, but you're not quite seeing it step up as much as you'd like?
Well, that's a great question, and I would say actually have a very clear sense of that. I think that what physicians share, what makes them physicians, is that they went into it to take care of patients. And ultimately, the conversations that people have to be having in boardrooms and as they try to figure out what to do with all those employed physicians can't be, do you get to make more than I get? Do you get to make what you made last year? Those conversations have to be about what's best for patients. They have to be about how do we meet the needs of the people we're supposed to serve. And they have to be structured that way. And they have to be structured that way by the physician leaders who are leading them. I would say that the only legitimate conversations to be having in an environment of less is how do we take care of our patients. And I'm not seeing as much of that as I'd like to. I'm seeing a lot of shadow pricing and following fee-for-service allocations. Two quick things to share. I'm stunned at the number of physician practices I'm learning about who measure productivity based on cash collections. And let's just start with, that says that a group of doctors are looking at each other and saying, we think Medicaid patients are worth 40% less than Medicare patients. We think that commercial patients who are well insured are worth more than Medicare patients. That's what we're saying to each other. And I will say that one of the proudest innovations, one of the things I'm proudest of that I did at Greenhouse, and I know we're out of time, was,
You go right ahead.
was that we were a level 3 patient-centered medical home. We were doing a ton of patient care by email and telephone. And as the owner of that practice, I came up with shadow pricing for email and telephone and added it to the physician productivity metrics. And I said, nobody's paying me for us to do this. But as we look at each other and say, what does good patient care look like? It looks like that. And I don't want you to feel like when you're sending emails on Thursday night, nobody recognizes that as a contribution to patient care. Actually, I do. And in running my own business, I could do that. And in all of you as leadership in healthcare organizations, you could do it too. And I think the more we have those conversations, the better off we're going to be.
Rich, thanks very much for the presentation, and thanks for the challenges.